Good afternoon. I think it's fine. You can start. Dieu-Donnee.
Okay.
Yeah.
All right. Good afternoon, everyone. As already stated, Dr. Dieu-Donnee, resident with the Obstetrics and Gynecology Unit at the Tamale Teaching Hospital. This afternoon, I'm presenting on assisted vaginal delivery, and my supervisor is Dr. Sanwe. This topic is quite important because it's something that we do as midwives or as people who are working in the maternal health field. It is also called, another name for the assisted vaginal delivery is the operative vaginal birth. Other jurisdiction call it that way, and it refers to a birth method in which the clinician would use an instrument, forceps, or a vacuum to be able to extract a fetus from the vagina, and sometimes with or without any maternal support. The decision to use an instrument to assist has to balance with, vis-a-vis the maternal, the fetal, and the neonatal risk, and also the benefits against the benefit of the procedure, and then to also with respect to other alternatives that may be available, such as cesarean section or expectant delivery. So this is the outline of the presentation. So like I think I already mentioned, this is the definition. It refers to delivery in which the operator uses a forceps or vacuum to assist a mother to deliver the fetus. The instrument is usually applied to the head, and then the operator uses traction to deliver the fetus. And usually it's done during contraction.
Hello.
We'll learn more about that later. So it was initially performed on mothers who have high risk of maternal mortality, owing to the fact that they are having obstructed or prolonged labor, and to also save their lives. And initially, the precedence to do that was to rather save the mother, irrespective of the outcome of the delivery. But that is actually not so in modern times. The incidence is about 3.6 to 4% of all deliveries in the United States. In the UK, it's 10 to 15%. In Ghana here, data at Kolebu shows that it's about 1% of all deliveries. Worldwide, with respect to the advanced countries and then the middle income countries, you have the incidence reducing, especially in the middle income countries and then the lower income countries, because more people have geared towards using cesarean section to rather deliver, because of sometimes the complications and the lack of expertise, and even the availability of the instrument. So why is this procedure done? What's the mind behind it? The goal of it is to mimic spontaneous vaginal delivery and also to expedite delivery with the minimum maternal or neonatal morbidity. Indications for the operative vaginal delivery may vary. The indications may vary based on the choice of instruments, whether it's forceps, whether it's vacuum, aspects of prevailing safe clinical practice based on where you are located, the risk of physical and then psychological complications that are associated with this, and also the whole fetus habitus, which we will look at it later. Women should be encouraged to, have continuous support during labor, especially whilst anticipating that they may end up with expectant delivery. So whatever it is, especially with the use of pathograph, if they need to be augmented, if they need to be monitored, and then to be helped so that they will not get to a point where the labor is progressed, it should be done. So it will reduce the need for operative vaginal delivery. The use of upright and lateral positions at birth has been shown, and also the use of epidural. The epidural analgesia further progresses the course of labor, and also can result many times to delayed second stage. So its use can reduce the need for operative vaginal delivery. We would before we look at the indications, I would like to state that the assisted vaginal delivery can actually be used to shorten the second stage for some conditions that sometimes require minimal to no maternal exertion. So we'll look at the some of those indications, I mean, as the slide is showing. For example, in maternal medical conditions such as cardiac disease, that you want the woman to deliver in a very short time so that she doesn't have to stress herself and then worsen the condition. It can be used if necessary. And then also for neurological and then muscular diseases like myasthenia gravis that would affect contraction and the whole process of labor because it affects the muscles. You can help the woman with this type of delivery. Also for proliferative retinopathy, women that have these conditions sometimes may become blind during the whole process of delivery. So you don't want to, if the labor is prolonged, so you want to shorten the progress of the labor so that they can deliver, and then you prevent all the complications that can come from this. So the inadequate progress in the second stage, from the Association of the American Association of Gynecology, they came up with this, developed this guideline to reduce the number of cesarean sections that are done due to poor progress. So usually in NOLIP, it's allowed that second stage can be delayed for up to about 2 hours or 3 hours if the woman had epidural anesthesia during the labor, and then 2 hours if there is no epidural anesthesia. If it's a multiple, it can be delayed for up to 2 hours. Second stage, that's the second stage, that can be delayed up to 2 hours and for epidural, and then for 1 hour if there is no epidural. And we have to also note that it's not just about the delay. You have to take into consideration the fetal heart tones, whether they are normal fetal hearts, and then also the general maternal conditions that the woman has. Because so because of this, there is not really an absolute, there is really no absolute indication. Most of the indications are not absolute because sometimes you need to compare a lot of factors, the maternal conditions, like I already mentioned, and then even the fetal conditions as well. So the maternal conditions, one of the major things too is also maternal exhaustion or maternal fatigue. So for patients whose second stage are prolonged because of this criteria, and sometimes they have normal fetal heart tracing with no other indication to expedite delivery, you would need to actually evaluate the need for an assisted vaginal delivery compared to an expectant delivery, so that you can manage. Sometimes you would have to even go ahead if you assess. For example, if you assess and then the woman is now, initially the descent was very high, and then now the fetal presenting part is descending very well, even sometimes maybe slowly, but I started descending very well. And then sometimes if she's not contracting adequately, and then you may have to augment with oxytocin. And then you also notice that she may be now pushing more effectively. You can give her some time and then allow for expectant delivery if need be. But sometimes, especially what favors for the assisted vaginal delivery is when you notice that the progress seems unlikely, even with the fetal station. With respect to the fetal station is still the same. If it's minus +2, if it's +1 or 0, it's still been the same for a very long time using the pantograph and all that, and the position hasn't changed much, and the woman is exhausted. You don't want to risk any further. You want to give her a try to see if doing the assisted vaginal delivery would help her. There are also some fetal indications that can sometimes make you take a decision to use instrument for delivery. If you suspect an immediate or impending fetal compromise, for example, cord prolapse in the second stage, which is quite rare, if there is fetal hypoxia or imminent hypoxia, which we all know as fetal distress in the second stage, because if you consider the time that you need to rush the woman to theater to deliver, and then you can use an instrumental delivery to deliver, checking your time and all the things you have available, the assisted vaginal delivery can help to deliver the baby faster. And also delivery of the aftercoming head when you are doing an assisted vaginal breech delivery. Let's look at some contraindications. So there are relative contraindications. Most of the contraindications are actually relative for babies that they have during prenatal diagnosis, they were diagnosed with fetal bleeding disorders such as hemophilia, thrombocytopenia. You don't want to try because sometimes the risk of some of the instrumental deliveries have a higher risk of, we'll look at the higher risk of tentorial and then intracerebral bleed. You don't want to try it. Predisposition to fractures, for example, in osteogenesis imperfecta, where there is demineralization of the bones, if the scalp already has an issue with mineralization, you don't want to try it because the risk of fractures are very high. And these can be picked up with ultrasound during antenatal visits. If the head is not engaged, it's an absolute contraindication. We'll look at it. Brow or face presentation. If there's a suspected CPD, that's cephalopelvic disproportionation. This, I want to state that extreme prematurity has been shown that if you apply an instrumental delivery to it, there's a high risk of bleeding, intracranial bleed. And so the literature states that if you have, especially gestation of less than 34 weeks, because of the risk of the bleeding, you don't want to try it, even though some literature says is relative. Also, the safety of the extraction between the 30, even the 34, after 34 weeks, between 36 weeks has not been made certain. So it's not like something that is a clear cut that you can do. So we'll look at some prerequisites for the instrumental delivery. Like I already mentioned even mentioned some of them, but first of all, you should have a skilled operator. The clinician should be well versed in how to use any of the instrument that is available. He should be very skilled and even skilled enough to know what the prerequisites are. And the woman should be informed. She should be taken through thorough counseling on the procedure, what it is, the complications, and also she should understand that if it fails, you would head to theater. She should be able to consent to it. And then the head should be engaged. That's what I mentioned. At least 2/5. Other literature says 1/5 descent. The head should be palpated abdominally about 1/5 before you would think of. Then it means that the staging is from 0 upwards, so that you can be able to have success when you apply the forceps or the vacuum. There's a mnemonic. There's a mnemonic for, interestingly, the mnemonic is forceps. So it's easier. It's a bit archaic, but most of the things are still what we use. So the F stands for full dilatation. The full dilatation is usually for forceps delivery, but the literature says that sometimes in vacuum delivery, you can have up to about 8 cm. If it's an emergency, you can actually attempt and try. And there's been shown to be some successes. Also, the O would be for occipital anterior position. Sometimes it may be occipital posterior, which is very important because the position can also determine your success rate. In other, sometimes the O is also used for obstruction. So it means that CPD should be ruled out. The membrane should be ruptured. The woman should have catheter to drain the bladder, because you know a full bladder would affect the descent of the head and also even the risk of a bladder injury. Episiotomy, it's quite controversial. Others think that it can be done, but a lot of studies that have been done have been shown that there is really no benefit of doing episiotomy with respect to the complication that arises from it, whether it's bleeding, whether it is tears, whether it's even neonatal complications. People that episiotomies were not done and those that had episiotomies done during assisted vaginal delivery, the complications were not varied. So it may or may not be beneficial. But sometimes, based on the clinician's assessment, episiotomy can be done. If it has to be done, it has to be a mediolateral or a medial episiotomy. Sorry, a lateral episiotomy, not a median type. So anesthesia, pudendal block, either a pudendal block or neuroaxial, like a, what do you call it, a spinal epidural anesthesia based on, it's been shown that the pudendal block is much more effective when it's the vacuum, because, you know, the vacuum does not stretch to the walls of the vaginal wall. So the pain is not as much compared to the forceps. The forceps would need a much more effective analgesia, and the spinal analgesics or the neuroaxial analgesics can help. Like I already mentioned, the station should be at level 0. It should be the presenting part should be at the level of the ischial spines so that you can have success. So the choice of the instrument, whether to use vacuum or not, actually has to do, like I already mentioned, has to do with the instrument that's available to the clinician and the expertise. But they all have their advantages and disadvantages. The vacuum, when it's used, has been shown to be relatively easy to be used, and also the extraction can be done when in the occipito-posterior position and at low stations. That's actually one of its benefits. So it means that when the head is way down there, it's easier to use a vacuum delivery. Also, you need expertise, but not as much as the forceps delivery. Also, the availability of the instrument counts. The vacuum is less traumatic compared to the forceps, and you can easily apply. You can easily assemble, and then you can easily apply compared to the forceps, which needs much more, you know, expertise to be able to know how to handle it. But however, the forceps has higher success rates because usually when you apply it, and it's usually applied when compared to the vacuum, when the station is a bit high. So when the forceps is applied, it's unlikely to detach, yeah, because it's very fixed to the head of the fetus. It also can be used for preterm delivery. Like I mentioned, that extremely preterm is not recommended. But if you have to use for preterm delivery, say those that are between maybe late preterm, 34 to 35 weeks, and you have a forceps, is preferred because the risk of having the tentorial and the intracranial bleed with the application of the head celastic cup or the head of the vacuum is much more reduced. So these are some types of forceps here. Simpson forceps, Elliott, Tucker, McLean, Keeland, Pipers. There are a few other ones, but the unfortunate thing is that I have not seen forceps. I've only seen pictures, but I haven't even seen forceps and how it's done. It's not really something that is done. It's almost, I mean, getting out of the system, even though in some advanced countries it is used. So these are some images about the forceps. The forceps delivery, there are some classifications, which the classifications is based on the station and then the extent of the rotation of the head, and it correlates with the difficulty. That's like the level of the difficulty, and then the risk that is related to the procedure. So that's how they've classified the type of delivery with respect to the forceps. So with the classification, we have the outlet's forceps delivery. With that one, you have the leading point of the fetal scalp, point of the fetal scalp at the pelvic floor, and then also at the perineum. So you have the scalp. The scalp is visible at the introitus. You don't even need to part the labia. You just see that the presenting part, the leading part of the presenting part, is just at the perineum and it's at the pelvic floor. And usually the rotation is less than 40 degrees in the occipito-posterior position. The low forceps, you have the leading part of the fetal scalp at station +2 or more. For a forceps delivery, that is a mid-cavity forceps delivery, you have the fetal head that is engaged, but the leading point of the scalp is above station +2. I think I already mentioned some of these things, the fact that you need consent for the procedure and all that. You need to clinically assess the woman, very important, by doing a vaginal examination, pelvimetry, actually, to be able to assess whether, because sometimes the woman might even be having a CPD, and then you don't want to go ahead and then deliver her because you know that you will not achieve any success. So you need to really assess the pelvis to check the size of the pelvis, the fetal head, and also the descent. The descent is done abdominally, and then the station is done vaginally. It's very mandatory so that you have a good outcome. There must be no doubt about the position of the fetal occiput. You need to know the relation of the fetal occiput with respect to the maternal pelvis. That would also help you to assess the position as well. There are also other procedures or other prerequisites that are not really prerequisites. I mean, you may or may not want to do them. It's been shown that sometimes you can use ultrasound because ultrasound has been shown to have, in many times, results in about 20 to 40% would show and will be able to assess better the position and the station, sometimes more than doing a pelvic or a vaginal examination. So in places where this is done, or you have somebody who has expertise in assessing for the position and then the position and then the station of the fetus, to know which type of assisted vaginal delivery or instrument to use, or whether not to even try the assisted vaginal delivery, you would want to go ahead and do this. There's also been controversies on whether antibiotics can benefit pre-procedure, before the procedure, and even after the procedure. The World Health Organization has recommended the use of IV amoxiclav, about 1 gram, within a period of about 6 hours as prophylaxis to prevent infection because of the instrumental use. And also sometimes, especially if you have to do episiotomy, you need to put the woman on antibiotics. So with the forceps, you need to, I'm not really going to go into details in the forceps because it's not something that we have available or easily done. There's the vacuum. When I get to the vacuum, I'll talk about the procedure in detail. So you need to assemble the forceps, and then it will face the maternal pelvis, and the operator's hand will guide the insertion of the blade sequentially to avoid damage to the maternal tissues. The blade is usually a left and then a right blade. One goes in before the other. There's a whole procedure for it. With the next contract, so once you insert and then you clip, there's a clip. So you clip so that it locks. Once it locks, then with the next contractions or even a maternal effort, because sometimes you don't, with assisted vaginal delivery, it's not all about contraction, even though it's very important to help with the success rate, but sometimes it may just be a maternal effort. The forceps are locked, and then you apply traction to deliver. The traction should be synchronous with contraction and maternal efforts and in the direction of the pelvis. So it goes downwards and an ever-increasing upward, so downwards and upward traction as the head is delivered. When do you abandon the forceps delivery? You abandon the forceps delivery if you have failed attempt of about 2 times. So you try twice, knowing that all the prerequisites, knowing that you apply the instrument well, and then you fail twice. Others also use a time range of about 15 to 20 minutes, that within that time range, if all you have done is not helping, and then there's no descent, I mean, with every effort you're trying to, there's no descent, the baby's head is not out, you don't go further, you drop, you throw in the towel. So these are images to show the forceps delivery. Let's look at the vacuum extraction or the venous delivery. So the vacuum extraction or the ventrose delivery is a type of instrumental delivery in which you use a vacuum extractor to achieve the vaginal delivery. It is actually more frequently used in recent times compared to the forceps, like I already mentioned, because it's easier to be used, and also the application is much easier, and you don't require a lot of training to be able to use it. Also, it's also because of the declining use of forceps. So a lot of people resort to the vacuum rather than the forceps. The prerequisites for the vacuum is just like the forceps. It also uses the same mnemonic forceps. But I mentioned that with that one, the full dilatation, that is if you don't necessarily have to have a full dilatation of at least 8 centimeters. If you are in a hurry, you need to achieve delivery, or it's an emergency, you can attempt it. And it's been shown that there have been some success rates. So these are some images or examples of, there is the Manstrom type of forceps, and then Kiwi. Where I am training, I see more of the Kiwi forceps available. I don't know for other places. So the Kiwi forceps system is the palm pump technology, which puts complete control in the hands of the operator. And then it uses traction, uses force, traction, using pressure. It has a flexible stem, which enables the cap to be placed over the flexion point, no matter the position of the fetal head. And it's disposable for convenience and safety. But I mean, in our jurisdiction, usually it's sterilized for reuse because of lack of its availability. So how is this forceps delivery done? So like I already said, you need to ensure that all the prerequisites are met, and then that's counseling the patient, all that, telling the patient about what you're going to do, the complications, the failure, and all that, and what's the next step if it fails. And then after that, you get an informed consent, and then in a sterile condition, donning your sterile gloves and all that, you need to assemble your instrument and text the instrument to see if they are functioning, if the pressures are working, if they are functioning. Sometimes you can use your palm to just test, release, and see if it can actually pull the skin on your palm to see if it's functioning. And then you administer the anesthesia. I already mentioned anesthesia to help so that the woman will be a bit comfortable, and then it can increase your success rates. You need to select the appropriate vacuum cap size, and also examine to know the position of the fetal head. You need to examine to know what position, whether it's in the occipital-posterior, occipital-lateral position, and then locate a point that's called the flexion point. The flexion point is 3 centimeters anterior to the posterior fontanelle, and then there's 6 centimeters posterior to the anterior fontanelle, and it's along the sagittal suture. That's where the flexion point is, and that's actually where you put the cap there. So you part the labia, and then you apply the cap. After applying the cap, you need to ensure that there are no maternal tissues that are trapped within the cap by running your fingers around the edge of the cap. Also, after that, then you can generate pressure. Initially, you start by generating pressure of about 0.2 centimeters of water. And then you run your finger around the rim of the cap again to be sure that no maternal tissue is trapped. Then after that, you increase the pressure from the initial 0.2 to 0.6 to about 0.8 centimeters of water. Then wait till she contracts. When she contracts, pull with the uterine contraction, and then with the mother trying to bear down. You can use one hand. Actually, you have to use one hand to pull, and then you use the other finger to be able to you put the other finger at the edge of the cup, so that if the cup is slipping off, it will be able to hold on to it, and also sometimes prevent liquor and blood from spilling all over you. Then you pull in the direction, of, the pelvis. So you come downwards, then forward, and then you pull upwards. So downward, forward, and upward as the head emerges out of the pelvis. And then you assess the need for episiotomy if need be when the head crowns. And when the head is delivered, you now release the vacuum pressure and then you remove the vacuum cap, the cap. And then you clean the baby and then you continue deliver anterior shoulder and posterior shoulder, the rest of the body, and then you continue with your active management of the third stage of you deliver a placenta, then active management of your third stage of labor. But very importantly, you need to hand this baby over to a neonatologist or the NICU sometimes, or call them to come and assess because of all the complications that come with this procedure. So this is what I actually explained. I think I already mentioned. So when do you abandon a vacuum extraction? It's actually also the same thing. That's when you have two detachments of the suction cup or it pops off twice during traction, and then you can't there's no advancements, there's no descent, there's nothing. You need to suspect a CPD and continue the procedure and then go ahead and do an abdominal delivery. Maternal complications that can arise from assisted vaginal delivery can have maternal soft tissue injury, postpartum hemorrhage, infections, psychological trauma as well. The postpartum hemorrhage, of course, will come from all these soft tissue injuries from the perineal tears, up to sometimes if you even have to do a episiotomy, it ends up in anal sphincter tear. You can have profuse bleeding, infection, and then it can even affect subsequent deliveries. The fetal complications commonly, especially with the vacuum delivery, is intracranial hemorrhage and infantile death. Cephalohematoma or subglial hematoma. That's why the babies need to be assessed by the NICU. Birth asphyxias, trauma, facial scalp, and neurodevelopmental deficit, which has been shown, some studies that have been done has been shown that babies that have been followed up after delivery with assisted operational delivery have not had any neurodevelopmental deficits. So to conclude, the goal of instrumental vaginal delivery is to mimic the spontaneous vaginal delivery. It expedites the delivery with a minimum of maternal and neonatal morbidity. It reduces the resort to unnecessary cesarean sessions. These are some researches that have been done, currently ongoing, pertaining to the assisted vaginal delivery. Very important to mention is the Odon device, which is in, I have an image there. It is in trial use at this moment, multi-country trial use of this device. It's a new low cost and handy device for delivery of fetus during prolonged second stage of labor. So that's how it looks. It's a disposable low cost device for assisted vaginal delivery. It has a rigid plastic cup that attaches to the head of the baby. The plastic tube connects to a cup, to a standard 50 cc syringe, and then the handle attached to the rigid plastic cup to help pull the baby out. So I have something here that you can read on about the procedure, actually. These are my references. Thank you. Thank you.
Hello.
Hello.
Dr. Dominic, can I
Thank
just
you,
part
Dr. Donnee, for an
comments?
excellent presentation. Now I'll move on to questions, discussions, and comments. And it's open to the floor. We can either type our questions through the Q&A or the chat box for us to read, or you can put up your hand so that we'll mute you for you to ask any questions. But before that, Dr. Eden.
Yes.
Hello,
Thank
Dr.
you so
Eden.
much. So, Dr. Donnee, Thank you for the wonderful presentation. I think she has done justice to the topic. Largely, it's a skill that is being lost, but as she has already mentioned, it's very important. It has served over the years to be the middle ground between going directly for cesarean section, i.e., and the normal vaginal delivery. So, importance of it, obviously, it eliminates some of the complications of cesarean section. Immediate complications will include your trauma, your hemorrhage, infection, prolonged healing and pain related to cesarean section, and long-term, some of the complications like a previous cesarean section scar or adherent placenta that you have to deal in subsequent pregnancies. So if you select patients carefully, you are able to achieve vaginal delivery and avoid cesarean section with these complications that I've mentioned. Largely, the two types are what she mentioned, the forceps delivery and the vacuum-assisted delivery. The prerequisite she has explicitly mentioned, you would always want to rule out any contraindication to a vaginal delivery. Then you look for evidence that there's sepal-pelvic disproportion. Then you obviously get the consent of the patient, and you go on to assess. The service must be fully directed, particularly in the case of a forceps delivery. Service must be fully dilated, head must be engaged. So it should be at the level of mid-pelvis or lower. So station of 0 or more. And then the membrane should have ruptured. And you should be able to determine exactly the position of the baby. We don't want a situation where you apply the cap randomly. We know that the fetus in the pelvis in the normal vertex will be what? Flexed, properly flexed. And the properly flexed, the presenting part is the vertex, the denominator. And she mentioned that the point of application is what we call the flexion point, which is taken to be about 3 centimeters anterior to the posterior fontanelle. So you locate this part, you palpate your sagittal suture and run your hand along that line. You locate the posterior fontanelle. Then 3 centimeters from that. Usually, the indirect way of determining is that if you apply the cap very well, the posterior edge of the cap should be on the posterior fontanelle. Then you know that you are at the flexion point and on the sagittal suture. Once you've applied the cap properly, you apply your traction. So the traction, she rightly mentioned, should be perpendicular to the cap in the case of the vacuum. And you pull along the pelvic axis. The non-dominant hand usually will protect the cap, the thumb will protect the cap, and the index finger will be palpating the skull. It's important you recognize this procedure. The importance is that there are some that during your procedure, you only succeed in elevating the fetal skull away from the bony pelvis. So if you are palpating, you'll be able to tell that there's no actual descent. It's just the scalp that is being pulled. So you have to abandon your procedure. If you're doing it rightly, you will notice that there's progressive descent. In terms of complications, you can have fetal maternal. Generally, I would say that forceps are prone to more maternal related complications, so trauma to the mother more. Whereas vacuum usually will predispose more of the baby to fetal scalp injuries, including cephal hematoma, as she has mentioned. So yes, she has done a brilliant presentation. Not to repeat what she has said, we'll listen to questions, then we'll address them. Thank you so much. Yeah.
Thank you, boss.
Okay, thank you, boss. Right now, the floor is open for everyone. If anyone has a question, there are 2 ways. You can either type it through the chat box so that we can read it out, or you can kindly raise your hand so that we'll unmute you to contribute to the presentation. Dr. Donnie did a good job by doing it within time so that we can have a lengthy time to discuss our shortfalls and clarifications from the presentation that she just did. So while we wait for questions from our participants, we can kindly look at the chat box. You see that we have a lot of social media handles where we can all like the pages or join or tweet at them. The presentation too was also recorded, and so in due time it will also be put on our YouTube channel so anybody can have access to it. So kindly take note.
So whilst we're waiting for the questions, I'll just probably continue adding. Anyone, when I see a hand, then we'll stop probably. So in terms of the antibiotics, she mentioned that that's one of the controversial areas. Generally, routine antibiotic is not recommended. It's not a recommendation at this present time. So you need to assess. For instance, if obviously there's prolonged labor and is the indication for the vacuum, then you'd probably want to consider that. But if it's on fetal distress, then you're doing your vacuum, you may not need to give routine antibiotics. In terms of what we call sequential or usage of both forceps followed by the vacuum for extraction, that one again is discouraged. It's been shown that the morbidity is high. So use your vacuum, then when the baby comes down, descends adequately, then you continue with the forceps. It's been shown that the mobility is high, so it's something that is largely discouraged. Yes. Is there any question at this point? Or I can?
No, please.
Okay. So is it that Dr. Donnee has confused everyone or has brought all of you up to speed?
There are two ways to it. It's either she's
Yes,
confused
exactly.
everyone or we totally understand all that she said.
Exactly. So we'll give some few minutes. If we don't get any response, then we'll assume the former.
Hello.
Yes, hi.
Yes, this is Dr. Hawa. I think that the silence just buttresses the beginning of the presentations, Donne's comment that we are not doing these procedures quite frequently these days. Even in our own setting, we quickly will run to the theater instead of trying to see whether we can assess a woman who has come with delayed second stage to have a vacuum delivery. So it's one thing we should look at so that it's a way of reducing our cesarean section rates. If we adequately assess our patients, pick those who can have a successful assisted vaginal delivery, it is so helpful. So that's just my comment, just to break the silence. But there's a hand now.
Hello, probably just to add, whilst we're waiting for the question.
There was a hand. I saw a Eunice.
There's a hand? Okay.
Yeah, Eunice.
Yeah, there's a Vital Fori.
Oh, Vida. Okay, I saw.
Yeah, Vital Fori. Kindly unmute yourself. I've asked you to unmute so that you can ask your question or your contribution.
Hello. Vida, we're waiting for you. Or any other person who has a question.
Hello.
Yeah, hello, we can hear you.
Good afternoon, all.
Good afternoon.
Thank you very much for your wonderful presentation. My name is Forgive. I have a little confusion that is under the contraindications. Doc made mention of phase presentation as one of the contraindications, but since it has appeared under the indications too as well. So my confusion is as at when do you decide to do it a phase presentation? Thank you.
Dr. Donnee, you want to answer that?
I don't remember. I think I listed it under contraindications.
Yes. So just to add,
But
we mentioned the point of application as being the flexion point.
yeah, the flexion
So,
point and the flexion
so
point is
exactly.
better.
So if it's phase,
Yes.
it will be a deflex presentation. So you will not be
Yes.
able to apply your vacuum adequately. That's why you need to determine the position. So it rather should be a listen.
It should be a contraindication instead.
Exactly.
Yes. I think it's under contraindications rather. If she can hear me.
Any more questions, comments, contributions? You're welcome. We still have quite a bit of time to get to the hour mark.
Whilst we're waiting for the questions, I want to just add a bit to what Dr. Howard said. I couldn't have agreed with her more. I think that gradually, because of litigation and other things, people who have gone full cycle. The practice was fading out there, but now somehow strangely it's picking up. And rather we in the third world are rather shy away from it. So most of our facilities are not really practicing this. So these are skills that are becoming rare by the day and getting lost. Particularly the forceps, like Dr. Donnee said, I mean, I don't remember the last time I did a forceps delivery, but the vacuum is relatively easy to learn. It's been shown that for people that you properly select, you sample and select properly, the risk is very, 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 very minimal. If you rule out your contraindication, to vaginal delivery, you select a baby of appropriate size, adequate pelvis, and then you look out for the other prerequisites. Usually the risk to mother and baby, as we have enumerated, are very minimal. So it's something we should encourage that we pick up. Some of the cesarean sections that currently we are doing are really avoidable if we want to use assisted vaginal delivery.
Okay, so I don't see any hands up in our participants list, and I don't see any questions too also in our chat box. So I think today we can call it a day. Thanks so much, Dr. Donnee and Dr. Eden, and our ever-present Dr. Ha for today's wonderful discussion. We hope you all learned a thing or two about assisted vaginal delivery. Hopefully we'll come your way next week or some other time with another fruitful presentation. Any more contributions from any of our co-hosts, moderator?
I think it's fine. Thank you so much for the opportunity. And Dr.
Thank you
Donnee,
for the
thanks for a
opportunity.
great presentation. Yeah.
Thank you, boss.
Okay.
Thank you for supervising my work. Right.
Okay. All right. Have a wonderful weekend. Bye.
Okay. Bye.
Bye to everyone. Bye.